sessions and trying to take a moment to listen to everybody who's on the call, who's been tuning in for the last, I think, around 8 weeks now, to hear about, really what's going on in the field, and also understand what is the next iteration of this, and like what are the future topics that we want to cover, or what are the real needs that we have available. So what I want to do is today, we're going to co-moderate. So Tom Quinn, Megan Harrison, Anna Kalbarczyk, and I are all on the call, and we'll all be pitching in to take feedback and questions. But this is an active discussion today. We're going to split the session into 2 parts. The first is I just want to ask one of my colleagues, Laura Pugh, to review some of the changing epidemiologic data. I don't think we've done that for some time, especially across countries and regions. And I want to use this as a pulse check to kind of, get a sense of where the pandemic is. When we started this session series, I would look at the Hopkins website on a daily, or maybe an hourly basis, and I'd be horrified when the numbers went up. And when the numbers went past 1.5 million, I think I just couldn't look at it anymore. So it would be nice to do a pulse check and see what's changing and where the changes are happening. And we'll spend about 20 minutes, we'll have like a 5-minute presentation, and then 15 minutes for people. I just want you to raise your hands, we'll unmute you, and you can tell us what you're facing in your countries and what the real issues are. And then halfway through this, I would like to propose that we change to what do we need to do with the series next. So we have about, next slide, we have 3 future sessions ready to go. One is on modeling and forecasting. June 25th is on NCD and cancer management during COVID-19. And then June 30th will be the impact of COVID-19 on key populations. And we already have recordings from all of the previous sessions. So I want you to think about, based on what your needs are, how can we best address those? And what future topics would you like us to consider covering as part of this seminar series? So next slide. Without further ado, I'm going to introduce you to Laura Pugh, who is a second-year medical student here at Johns Hopkins. As you know, that our medical students at Hopkins have been extremely supportive of this effort and have been contributing to all the slide decks and all the resources that you see. So Laura, please take it away and tell us what's going on around the world.
Great, yeah, so I'm just going to do a quick overview of what's going on internationally and kind of emerging hotspots that we're seeing and places where we're also seeing declines. So this map is of the last 7 days, places showing the number of new cases over the last 7 days. So as we can see, the United States, Brazil, Russia are kind of standing out as places with existing large numbers of cases. But we want to focus on kind of where the pandemic is going. And I think this figure is really concerning and also illustrative of what is going on throughout different regions. And so as you can see, even though we're hearing a lot about, potential leveling off in Europe and you hear a lot of that story, it's really the only region that's seeing persistent declines. And so you can see in Africa, the Americas, Eastern Mediterranean are seeing fairly exponential increases. Southeast Asia is seeing a steady increase in cases. The Western Pacific is pretty steadily low, and Europe is declining. And so through the next couple of slides, I'm just going to show breaking down by these regions what some of the key countries are and where the cases are really rapidly on the rise. So to give you a sense of what the next couple of slides are going to be, on the left is the cases for June 4th, and then on the right is the cases for June 16th. So it's over the last 2-week period, what the case numbers have looked like in the top 10 countries in each of the regions that we're going to go through. So in the Americas, these are the top 10 countries with the highest numbers of cases. And then I've highlighted those which have had a 50% or greater increase in the number of cases. So just as kind of a quick visual of where the cases are increasing most quickly. So you can see that Brazil has had just as many new cases as the United States has. Even though their existing outbreak is a little smaller, they're still increasing at a really rapid rate. We also see Chile, Mexico, Colombia, and Argentina as rapidly increasing in cases. Also notable, Mexico has a really high death rate compared to other countries who are reporting similar or even lower numbers or even higher numbers of cases. And so similar story in the Eastern Mediterranean, where many countries are having continued rapid rises in cases. Iran has been having their outbreak pretty significantly for a while, but Pakistan, I think, is really concerning. And they've gone from 85,000 cases to 148,000 over the last 2 weeks. And so given health system capacities, this is a really dramatic increase and is poised to continue to be concerning at slightly lower numbers of cases, but still seeing rapid rises are Egypt, Afghanistan, Oman, Iraq, and Bahrain. Iraq, for example, has had a 160% increase in the number of cases, going from 8,000 cases to 21,000 cases over a 2-week period. In Southeast Asia, the big stories are India and Bangladesh, both of which have high numbers of cases already, but are still rising pretty quickly. So India has seen more than 100,000 new cases over the last couple of weeks. Bangladesh is increased by 70% or so. And so both of these countries with potential for really large outbreaks going forward. Nepal has a smaller number of cases, but has gone from 2,000 cases to 6,000. So that's a really dramatic rise and is still something to keep an eye on. And I think transitions well also into the African region, where a lot of the case numbers are still really small, but in countries with smaller population sizes, we're still, despite seeing small numbers of total cases, the rate of increase is going up. And so there's still places to keep an eye on. And the big story in Africa is South Africa, which has doubled its cases in the last 2 weeks, going from 37,000 to 73,000 cases, and about doubling in deaths. And Nigeria is second in this region and still pretty far behind, but also is seeing a spike in cases over the last couple of weeks. And so those are two countries to watch going forward. And so I think this really tells the story of what to look out for going forward. So the left table shows countries that currently have the highest number of reported cases, and the right table shows those highlighted ones with greater than 50% increase over the last 2 weeks. And so there's really very little overlap between these two tables. And a lot of the countries that we have been thinking of as having these big outbreaks, they're slowing down. You see no representation almost of Europe on this right table, despite making up most of this left table that has high past reported numbers of cases. Brazil, India, and Chile stand out as places that do already have high numbers of cases and are also continuing to really increase. So that is definitely worrisome for those areas. And then on this right table, fast growing areas, both the Americas and Eastern Mediterranean are really overrepresented on this table, and have several countries within them that are seeing rapid rises in their infections, as well as India and Bangladesh in Southeast Asia and South Africa. And so just kind of key takeaways from this brief overview. Western Pacific continues to retain a relatively low number of new infections. Europe, the regional trend can obscure increases in specific countries, but overall as a region, it's on the decline. but that almost all of the hotspots that are emerging are in low and middle income countries throughout almost every other WHO region, especially the Americas and the Eastern Mediterranean. Southeast Asia and Africa also have specific countries that are poised to experience continued exponential growth and increased infections.
Thank you, Laura. So I think, you know, when I look at these numbers and details, I think I'm struck by, I wonder how much of this is contributed by like ramp up of testing. I remember early on in the US pandemic, so in the emergency department, we had tiers of testing. And so really only like very, like maybe like 1 in 5 individuals met criteria for testing. And the rest were like sent home as presumed PUIs or presumed COVID-19 infection. And then talking to colleagues across the world, I'm kind of hearing similar things. And so I wonder if there's like a bias in some of the data that we're seeing due to lack of testing. But I wonder if what the contribution of access to testing is. And then some of it may be that, you know, some of these countries got a head start, you know, maybe watching the US experience. And so is able to implement strategies such as contact tracing early on, early quarantine. And so I wonder if that contributes to some of what we're seeing too. I want to open this up because I think the purpose of today is to really listen to all of you who are like calling from across the world and to hear your experiences. So let us know in the chat if you would like to unmute or raise your hand, and we will unmute you. And you know, if you can exit the slide share, Laura, that would be great. Perfect.
Hi, Laura. This is Tom Quinn. And that was a great overview. Probably one of the biggest issues that come up, and I don't know in your review whether you were able to ascertain it, is the rate of testing. So WHO and even in the US, where the recommendation is that we get to below a 5% infection rate for the number of people screened. And even in the US, it was much higher, if you recall. We were at like 20% 6 weeks ago or more. Here in Maryland, we've gotten down to 5%. So we are trying to reach that benchmark. The more testing, obviously, the more comprehensive your surveillance of an area. But did you get a sense, because I hear from people in different countries, and I hope to hear from them today, that the rate of testing is low. And this is true in our target audience, LMIC, but particularly true in Africa, I would say. But I'd like to hear from other people outside, but I'll leave it for you to respond first, Laura.
Yeah, I think that's definitely true. I was just using WHO data to put this together, and so it's completely dependent on the data that's reported and available. And so in countries that have conducted fewer tests and have high positive rates of tests, I think that could definitely skew the data. Also, you know, in looking at countries with rates of death that are out of proportion to their number of positive cases, I think that definitely indicates that the testing might be skewed towards either a already sicker population and might be missing some of the positive cases that are having less severe presentations.
Right.
All cases that are not in like large level health facilities, that are more rurally placed, you know, because I think surveillance strategies that we have mostly likely to be in hospital-based facilities, opposed to in more rural or district level clinics. I have a hand. Moisi, can I invite you to speak? And would it be great if you could tell us what your role is and which country you're from?
Oh, hi. It's interesting to join the meeting today. My role is a researcher, and I'm calling from the US, I'm actually part of Johns Hopkins University. So the question that I have is the data that we saw on the bar graph. How was this data obtained? Is it from websites or from the country representatives specifically? And what program did Laura use to produce that graph? Thank you.
Yeah, so the data is just from the WHO daily situation reports, and so it was just comparing over the dates listed from those situation reports that list each country and their current cases, deaths, and then number of new cases each day and new deaths each day.
Yeah, so Moise, a lot of this is Department of Health reported data that the WHO is able to combine, which is a combination, which is a lot of it's active surveillance data, but there is a reporting bias in this. Peter quickly also shared with all of us on the chat world meters, which provides number of tests per countries and populations, so you can work out positive rates. Peter, thank you for sharing that. We'll make that available to everybody. I'm going to call Ghulam.
Sorry, the bar chart. I still asked the second question. The bar chart that was shown, what software?
That's from the WHO website, Moise.
No, the software that you use in producing the bar chart.
Which it was taken from the WHO website, so I wouldn't.
Oh, okay. Okay, thank you.
Send you the link. Laura, would you mind sending that to Moise in the chat? Ghulam Kader, welcome. Could you tell us where you're from and what are you seeing on the ground?
Good morning to you all. This is Qadir from Afghanistan. My role is advisor to TV program, and also I'm leading the contact tracing committee for the COVID-19 response at Ministry of Health. So for a country like Afghanistan, the tests hasn't been sufficient so far. Therefore, the government are prioritizing tests, and the number that reflected here is not the real number, because we are missing a large number of individuals that might have the COVID-19, but they were excused from the test because of the insufficient number of tests. And regarding the positivity rates, it says that when WHO says when it is lower than 5%, then it means that the countries are in a good path toward COVID-19. The question is how a low-income country like Afghanistan could know that we are there in the right path because of the limited tests, and that is only limited to those who were admitted to hospital. And on the other hand, we are using the clinical definition, which might show the probable cases, but not the laboratory confirmed cases. So in these, how this clinically confirmed cases should be reported, and what strategy you are proposing to a country like Afghanistan? Thank you.
Thanks, Kader. And I'm sorry about the loss of your colleague, Dr. Samadi. Our thoughts and prayers are with you and your team. So I just put out on the chat if there's any epidemiologists around there that are willing to answer this question. I think much of the experience that many of us have is based on disease processes that where we don't have a restriction of testing, right, per se, such as the HIV epidemic, right, where we're even able to do cross-sectional incidence analyses to really look at the true dynamics of the epidemiology of the disease. I think what you're saying is a challenge to everybody, and I don't think there's a clear-cut answer that can help respond to what is the strategy here. I think, the ideal strategy would be like blanket universal testing. There's some strides to understand the true prevalence, by doing antibody-based testing, right, opposed to just the viral PCRs. Tom, please rescue me if I'm going down the wrong track. And the antibody testing will tell us what the prevalence of having had that disease is within a population, not the number of active cases. But I think what our modelers are trying to do is trying to triangulate these various different populations and data sources to see if they can get a true inference of the underlying prevalence of COVID within a setting. Tom, anything you would like to add?
Well, I'm very sympathetic to the question because we started out in this country in the same format. You first do a case definition, you test those that are highly symptomatic and seem to be fitting that case definition. But when you do that, you're missing all the asymptomatics, you're missing the contacts, you're missing the mildly symptomatic or those that don't quite fit a case definition. And so one thing you can do, which is a little bit less expensive, you were absolutely right, Bhakti, the serology tests, which are far less expensive and can be rolled out pretty quickly in a country, will give you background rates of infection. That's all they do. They don't tell you about immunity per se. They don't they just give you an idea of the frequency in which this virus has been, past tense, has been in the population. So it's very good. And once you start seeing individuals that are antibody positive and they were asymptomatic or they didn't fit the case definition, then you really must increase the acute testing, the RT-PCR for active viral infection beyond those that are meeting that case definition. That's somewhat more problematic in low-income countries because those tests are much more expensive, but they're going to aid the health officials in knowing who's been infected, who's been exposed. Now you can start to do contact tracing. The serology test doesn't really help with that. So these two armamentarium of the diagnostics each provide an advantage to the health officials, but they gather different types of information. And the serology ones, there's a lot of tests now available. It's been scaled up. Countries should be able to access these kits now. And I think those in the health area should be able to start to do screening of populations to see what that rate of infection is. I know we're talking about doing this in Uganda, it's being done in South Africa, it's being done in Mali. Lots of discussions going on, and at least we can do that, and it should be done in Afghanistan. Thank you for the question, and it is a tough one. Hearing from people from the other countries and how they're struggling with this or are responding to that would be really worthwhile. So raise your hand if you'd like to add to that discussion.
Peter and Mima, I think I see a comment from you in the chat about testing availability for healthcare workers. So just like, I don't know if you want to like explain the question a little bit more, but from one of the, what I'm seeing here, it says, you know, I live in Baltimore and we're struggling with the number of tests and we're struggling with testing of our healthcare workers. To be honest, since day one in Johns Hopkins health system, and I think across many health systems, healthcare workers are priority one testing. We have very like broad criteria for what symptoms what symptoms are thought to be as defined as PUI, and we put healthcare workers in that tier 1 category, as it's extremely important to know if a healthcare worker is infected or not to protect our patients, but also our workforce. Are you having a different experience, or is there something you would like to expand upon? Peter, you're muted.
Hello, can you hear me?
Yes.
Oh, great. So yeah, I was talking about availability of tests. So all across populations. Yeah, I'm a bit exposed to what is going on in Kenya, and I've been trying to compare what's going on in Kenya and what's going on around me in the US. And so when you compare those two populations, availability of testing is much higher, I would say, in Kenya, in terms of where the population can go and get tested, in terms of access to testing, as compared to the US, which I found a little bit contrasting, in terms of what you think about low and middle income countries. So basically, that was my my comment.
I think like what you're actually seeing is differences within the healthcare systems and how the healthcare system functions. And so I face this daily in the emergency department, but everybody knows, right? So I was also COVID positive, and I also had to get my family tested. And so I had this challenge on multiple levels. And, you know, my conclusion here is that the challenge with the United States healthcare system is really our payer model, right? The heterogeneity of the insurance companies, the roles of different types of institutions, the fact that different institutions develop tests at different timelines, and then who pays for the test, right? We have actually seen this challenge when it comes to our HCV and HIV testing work across health facilities, right? So if you want to do routine testing or routine screening, then the challenge has been who picks up the financial burden of testing. I think, you know, in countries such as South Africa or Kenya, you have a different healthcare model where there isn't this added complexity of the financial burden of the testing because it's all run by ministries of health. I will say though, in the start of the pandemic, there was restrictions on testing due to lack of availability of tests. And we needed to, I think that, you know, we prioritize people where the test would change their health outcomes, in the sense that if they were getting hospitalized or needing a clinical trial, or if they were immunocompromised individuals or healthcare workers. But unfortunately, and now as things have moved on, we've been able to make testing more broadly available, even for individuals who have a few or limited symptoms and are otherwise well. But I think what you're seeing is this complexity around the health systems and the insurance companies. I'm not seeing any more hands being raised, so I'm going to switch gears a little bit. I'm going to take a comment. I see a comment from Peter that I'm going to read out, but Peter's saying, I'm enjoying the series. Thank you so much, Peter. We're enjoying putting this together. Actually, it's been very informative for myself as well. And what we would like to see more of is ongoing mitigation strategies in low-level COVID-19 contexts and success stories in maintaining and scaling up essential services and the use of digital technologies. Oh, and actually it's not Peter, it's Paula. So it's Paula, sorry. I apologize. But I think that's a great idea. So what I'll probably ask is that, you know, if people here are comfortable telling us their stories, and I think we would like to put a lens on different country-based experiences, but also with a focus on what are some of the technological strategies that you've been able to implement. What, you know, I've been working with a couple of groups, and one of the things we're exploring is Echo as a platform to do case-based discussions, WhatsApp groups, expansion of telemedicine services to provide care to, you know, sparse COVID numbers across multiple institutions, especially when you have limited critical care resources. So I'm going to hand over to my colleague Anna Kalbarczyk, and we're going to change gears and talk about the future of the seminar series and get your feedback.
And let me interject for a second, Anna, before you get started. And we'll end the data issue. But Pranab Chatterjee in the chat box actually highlighted that it's a website called Our World in Data regarding the coronavirus. And that has that overall positivity rate that I was referring to. For those on the call, if you haven't seen that website, it's really fantastic. My hat's off to those folks involved in that. And if you look in the chat box, you'll find the website. So I just wanted to give a thanks to Pranab for bringing that up. Thanks. Anna, back to you.
Thanks, Tom. So what we wanted to do in this next part for today was to go over a little bit of the evaluation results that we've gotten from the webinar so far, particularly focused on topics that people would like to see covered in this series, and then get a sense from those on the call if those are really resonating with you, or if there are additional topics that we could talk about, like digital strategies or success stories from different countries. So let me share very quickly this PowerPoint that just outlines some of the results that we've gotten. What I think is really fantastic is that a number of the requests that came in, we had already planned to discuss, or we've covered things like gender-based violence. Mental health was one that came up quite consistently, but here are some topics that I think we haven't quite covered yet. So role of political landscape and leadership, challenges with displaced populations, community health workers and community engagement, strengthening monitoring and evaluation systems, how to promote behavior change. Something that we've really seen quite a bit of is actionable steps. So really addressing misinformation, conducting community engagement, but going into really actionable strategies. One of the criticisms I think that we've seen on some of these seminar series and others is that the guidelines and the recommendations are quite broad, and it's hard to translate that into action. Effectiveness of mass screening and testing, engaging the private sector. This was a recommendation that came up quite a few times. And then a review of current policies and programs in low and middle income countries. So what are countries doing? What are we seeing in terms of effectiveness of these? How does it vary by different settings? So maybe I'll take a pause there. I saw some comments come in. Let me see if I can get that. Bhakti, maybe you can help moderate since I'm...
Sure, happy to do so. So Christina Ray Gorman talks about contact tracing, and she's an epidemiologist near Toronto. And that one of the big challenges they've had is isolating households. So we definitely talked about contact tracing, but implementation of self-quarantine or home quarantine, I think, would be an interesting topic. Thank you, Christina. Millie Kayong from sent us a little note about surveillance testing. So she was wondering if we could have a panel to include country experiences and technical updates like the one Tom just gave, because this is very confusing in countries. So how do you what is the strategy for country level surveillance that could be implementable? One thing I heard, Anna, was that this was from a colleague in Lesotho, but that when they have a PUI, they are struggling to ask them to go back to their communities because the communities aren't accepting those individuals back. And so what is some strategies or innovations around destigmatization of COVID-19? Because I think it's definitely real. People treat you like pariahs after you have COVID. And then the other thing that I've heard from colleagues in South Africa in particular is this, they're having struggles getting the healthcare workforce to work with COVID patients. And so healthcare workforce perceptions around COVID-19, and I think one of the innovation, I don't know if anybody's doing this that's on this panel, but how are you training or teaching healthcare workforce about the relative risk of treating COVID patients compared to, say, for example, MDR TB patients, which everybody's extremely experienced at.
Great.
Carrie Shannon, thank you for your comment, asked about strategies to for overcrowded communities where families do not have the capacity to self-isolate. As I'm going through this list, if any of you are experts in this area, like, let us know, because it would be great to have some speakers who are actually dealing with these problems in the field.
Yeah, I think one of the concepts that Bhakti and I had been discussing was really the next phase of this, incorporating some different speakers, not necessarily from Hopkins, but really people who are in the field who are working on these issues. And we'd love to invite people who are on the session today, people who have joined us in previous sessions, particularly who are having specific experiences or who have strategies that they think are working well, to reach out to us so that we can continue this.
Narges Qureshi from Iran is talking about general risk communication. So maybe we can get Johns Hopkins CCP to come into a session to talk about some of the communication strategies they've been developing as part of the recent funding award they received.
That's a great idea.
Kedar, sorry, one of the strategies was higher community transmission. So are any of my colleagues from India? India is very silent today on this chat. Usually there's a lot of people, but what about, how are my colleagues in India dealing with slum populations, or the large exodus that happened when shutdown happened and all those populations are migrating en masse? I'm sure that was a problem for transmission and epidemiologic control. Dr. Joanne Katz, humanitarian refugee health folks are thinking through the issue of what to do in crowded conditions. It would be good to get them to talk about this. Yes, I think that's a great idea, and we can probably reach out to our Center for Humanitarian Health. Other thoughts? I'm just reading them out. You're welcome to speak too. I'm sure my voice, although with my delightful accent, is quite monotonous.
I think one of our goals, not just to think about future topics, but really to get a sense of if people who are joining us are still finding this useful, relevant to their practice, and how we can help that. Are we helping by continuing to do this series? Are we taking up your time? Just trying to really gauge how we can best serve everyone.
Megan, I'm asking if you can set up a quick poll, and once she's ready, we'll ask that question, and I'll see if it can work in real time. So
That's a great idea.
Is going to be, if we were to continue this for another 8 weeks, would you be interested in participating? And just a yes or a no. So once that's done, any other thoughts? Dr. Katz, she's she's an all-time mentor and a good friend. She's like, do it if you have the energy. Well, the message is I'm no longer breathless when moderating.
That's right.
So that is a plus.
You sound much better these days, Bhakti.
You do, and I didn't want to bring this up with Bhakti on the line, but there are clinicians that are on the line as well, and one of the common questions we get are, what are the chronic consequences of acute COVID? So some people have developed some chronic illnesses, activities. Some are still on steroids 2 months out because of this post-COVID immune response. We haven't really gotten into the pediatric scenario and what was reported primarily in the US about these, again, post-COVID immunologic phenomenon, that mirror image, Kawasaki's disease. How much did children serve as potential sources of transmission? I don't know that that's been well studied, but it's something that should be addressed. And that's just I want the clinicians on the call to also raise, if you've got questions about this, what is the role of dexamethasone these days, and the debates that go around that, or what happened to hydroxychloroquine in the process. So I want to make sure we're also addressing clinical issues for people working in the countries that we try to address and service. So if you have questions,
I can
send
answer
them
the
in.
dexamethasone question because of the recovery trial. So it's available online. They presented their preliminary data, which shows significant decrease in mortality. I ended up having to review this last night, but what the dose of dexamethasone, let's be clear, is only 6 milligrams PO once a day, Q day, and only for 10 days, right? So that's much, much, much lower than we were using in our early goal-directed therapy sepsis studies, the Victor study, etc. And there is anecdotally a number of studies that did show higher mortality. It's unclear from the data that's been published, they've only released like their summary statement, what proportion of these patients had diabetes and what proportion of those patients had poor glycemic control. And remember, the population that the recovery trial looks at is hospitalized, intubated patients. Now, some considerations for low resource settings where you don't have ventilators as often is, can we extrapolate the findings from the recovery study to patients who are on high flow nasal cannula or non-invasive positive pressure ventilation, i.e. those who are also critically unwell, but intubation is not the criteria. Regarding the long-term sequelae, I think we should do a session on that because I think it is poorly known and understood. There is definitely mental health stigma at the end of this, the survivor's guilt. Too often I go to work and I see someone that didn't have a good outcome like me, and it's really sad. On the other hand, and it's complicated by being pregnant as well right now, but I'm being really transparent so that others realize, if you've been COVID as well, that 2 months out, I'm breathless all the time. And I have a little Miss Chatterbox, and I like to walk and talk, and I can't do both at the same time. And I've heard that from a number of people. So if there's any COVID survivors out there who want to share their experiences, I think that would be great. Megan, can you release the results of the last poll? And then the next question that you're going to be seeing is, okay, 96% yes, so we'll continue doing this. So the next question I have is based on Tom's query to you all is, should the focus be clinical or public health? And what should the frequency of the sessions be? Would you like to see 1 per week? Please, I don't think I can do that. 2 per month or 1 per month? So like, should we reduce the frequency, or we should have added as is? Twice a week.
Yeah, question number 2 is a little unfair. I would have added 1 more box and said both.
Well, should we withdraw the poll and add those two?
No, let's see.
No, I think let's withdraw the poll. I think because it would help to know too if about the timing, if people want to keep it at the current time. So if we could just we'll just redo it.
Right, Megan. So the options we want is twice a week, once a week, twice a month, once a month. And the second is clinical, public health, or both. She said 1 second. Megan's amazing, by the way. She's the clock, the mechanics behind all of this that keeps everything moving seamlessly.
And it is amazing how well Zoom has advanced during this epidemic. If there's one technology that has really expanded dramatically, it's Zoom. And I say that we don't advertise for them, they don't give us any support. This is just my personal perspective.
Yeah, I don't think Anna will mind me saying this, but she's writing a paper right now on the role of technology in supporting our trainees and some of the innovations that have come to light. So watch that space. The other thing is the children question, Tom. I think that data is coming to light. I'm really glad it came out after my child was sick, but I don't know if people are experiencing, any pediatricians in the group are experiencing cases, but I would really love to hear about what you're seeing, and I wonder what we're going to possibly miss as well. Okay, friends, the next poll is available.
While they're looking at the poll, the other question is about schools. You know, the reopening of schools and the proper precautions that need to be taken. If it was influenza, you know that the children are often the nidus of transmission. Is that the case for COVID or not? We need answers on that. We
just saw an interesting article put out by Global Health Science and Practice, and I think Natalie Kalbarczyk, I think I saw your name earlier from that journal, that said that that children are not for COVID for a number of reasons, and I'm happy to share that around with the group because I believe it's open access. It was a really well written article.
Thanks, Anna, and we could invite the group to a seminar presentation on it.
So Uncle Tom just called you a nidus for infection. He did.
I did not.
I did not.
I put a question mark there.
Okay, Megan, do we have the poll results? I really want to ask who is the best moderator, but I think that would be wrong. But I have
Oh, don't put us against each other, Bhakti.
Okay. So I think the consensus here is that we should reduce to once per week. But we should, we should get to start moderating. But the focus should remain clinical and public health. I think we've had a lot of public health. So I think we should, if you have clinical questions about management, please let us know. Sorry, it's bath time in the household right now, hence the waterfall. Any other parting thoughts, Tom, Anna, Laura, Megan? And I think we can wrap this session up. We'll work on incorporating, we'll work on reducing the frequency to once a week. So after June 30th, we'll go to once a week from July. And I probably propose that we do this on Thursdays, Tom, so because there is some other conflicting webinars that go on Tuesdays. Let us know. Actually, let's poll it. Tuesdays or Thursdays, friends, and then we'll call it a day. We'll incorporate some of the topics that we've discussed, and we'll strive to put on programming for another 8 weeks. One of the things that you can also ask for if you're interested is for us to revisit topics. So I have an intention to bring back Aditya and Will to talk about any nuances or new data on clinical management. We will probably bring back Dr. Manabe to talk about, and maybe Oliver Leyendecker to talk about the latest results from your diagnostics studies. And then the last topic, thank you, oh, she's naked. And the last topic that we...
I will not leave it closer.
Okay.
I will leave it open.
The last topic will be therapeutics. I'm sorry, everybody, but this is COVID reality. It's called being a mommy. So last poll, Megan, can we get up Tuesdays or Thursdays? And I'll ask Tom, Anna, Laura, and Megan to talk about any other last remarks.
Thanks, Bhakti. I think it's really helpful to get everyone's take on this, you know, just to see what would be helpful for us moving forward. I have to admit, I'm a little bit excited to go down to once a week since it's a lot of work for Center for Global Health team. So very many thanks to all of the people on the call who responded once a week. That was nice to see.
And I also want to thank everyone who tunes in every week, twice a week. To be a part of this, to ask your questions, to really get the latest information. We learned from you, and we really do like your comments after the fact, and we hope that this has been worthwhile for all of you that listen in. Time is precious these days, and we want to make sure that we're contributing to the information flow. So send us your comments, give us your evaluations. We're open to all types of critique, good and bad. Thanks very much for being a part of the series. And the results of the poll from Megan.
And Thursday it is. Tom wins.
Yeah, I do. That works great for me. Tuesdays are busy. For those, if you are interested in the clinical, and they have moved, I believe, to every other Tuesday, there is the Hopkins Grand Rounds Clinical COVID, which is on Tuesdays, 8:30 Eastern Daylight Time. You have to do the adjustment for your time zone. That is also available via Zoom, and that's every other Tuesday. It should be this coming Tuesday. So it's nice if we go to once a week and we're Thursday, they're Tuesday, and it's all clinical, but it's excellent, outstanding flow of information on the clinical perspective.
I posted the link in the chat, so if anyone's interested, they can find it, and we can also add it to our own resources page.
That's great.
And then we've also just started using Twitter. We're a little bit late to this maybe, and we have a new Facebook page. So we will post those details where you can find us on our website. But maybe like if we're going to meet a little less frequently, we can continue the discussion in the World Wide Web. So thank you, everybody. Good night. And for those of you starting your day, good morning. And we will speak to you next Tuesday.
Hi, everyone.